Very good. We'll go with our part 2 of cardiology. In the meantime, if you got any question or something, okay, please use the chat box so I can answer your questions. With the next section, with the neurology, we will go with a little bit of interactive also, okay, in the form of few MCQs so that you can answer few questions and you can have a little bit practice about how to answer the MCQs, okay? So previously, as I have described, we will go with the complex congenital heart diseases today, then a heart failure and few acquired conditions. The first one, which comes is basically complex congenital heart disease that's Eisenmenger syndrome. We have talked about it a little bit in the previous section also, but I just want to be more sure because you will get a few questions about Eisenmenger syndrome because that's kind of favorite questions for RCPI. So according to physiology, what happens here is if high pulmonary blood flow due to large left to right shunt or common mixing is not treated at early stage, then what we can get is basically we get pulmonary arteries that's become thick and resistance to flow increases. Those patients who have survived becomes less symptomatic as the shunt decreases because the pulmonary blood flow has been decreasing. This is the reason that they become less symptomatic. Eventually, at about 10 to 15 years of age, the shunt reverses and the young person becomes blue, which is really an Eisenmenger syndrome. And if this situation got more progressive, that can cause, I'm sorry, but that can cause death or right heart failure. Now, as we have described in the previous section, basically what we have to do is Eisenmenger complex is basically associated with any kind of congenital heart diseases that's basically from left to right shunt. So what we have to do in this condition is what's the treatment of choice? That's basically we have to prevent the right ventricular hypertrophy with early intervention for high pulmonary blood flow. Okay. And the second thing, basically, transplantation is not readily available, though medication to palliative pulmonary vascular disease is really available now. Most of the patients goes with the palliative care for this condition. Now, this is your complex congenital heart disease, the Eisenmenger physiology. Here, basically, what happens is there is a left ventricular hypertrophy first. That's basically causing the left to right shunt. But with the advancement of age and everything, progressively there's a right ventricular hypertrophy and there's a shunt reversal. But at this time, you know, what kind of issues have arise already? That is basically the tricuspid valve that's regurgitating a lot of fluid and everything. Okay, then there's really dilated pulmonary artery that's causing thickness and everything. This is the whole complex around that's causing all the issues in the form of cyanosis as well as right ventricle failure. Am I clear till this? I would say that give me a little bit feedback also. So it would be easier for me to just communicate with you and judge few things that if we are on the right track or not. And if you got any type of question or something, just let me know. Okay. Okay. The second thing that's really common, and sometimes we all get questions like that. That's atrioventricular septal defect. It's commonly found in children with Down syndrome. The first thing is, what's atrioventricular septal defect is a complete AVSD features a central heart defect with one of five leaflet valve connecting the atria and ventricle. I have one picture after our discussion so that you can see like what is AVSD and how it presents basically. So the large defects leads to increased pressure in the pulmonary artery. As in the previous section, we have described, our main goal here is just to prevent pulmonary hypertension, the first thing, and the second thing is to prevent heart failure. So that's what we are going on with every scenario, with every kind of situation. Now, the features that we get from atrioventricular septal defect are: number one, presentation is on antenatal ultrasound screening. That's really very evident. And number two is cyanosis or heart failure at 2 to 3 weeks of age. Here, it depends on if the defect is very large, they can present with the cyanosis early. If the defect is small, they can take like 2 to 3 weeks, but it depends on really, the cyanosis could be really less evident. Number three, there could be no murmur heard because the lesion is detected on routine echocardiography. The problem here is we cannot hear any kind of murmur because the defect is between atria and ventricle, and there's a no there's a nothing kind of like turbulence that's going on. That's why it's really sometimes impossible to hear any murmur. Now, the important thing here is you will get always a superior axis deviation on ECG. Here, the ECG, what we see is basically we will see AVL and V1, okay, and lead 1 also. That's how basically patient presents. And what else you have to remember is you have to remember differential diagnosis of superior axis deviation, okay? There are three differential diagnoses, and that's our Epstein anomaly, as we have previously discussed. The second one is tricuspid atresia, and the third one is atrioventricular septal defect. I want you to remember these three things where we can get a superior axis deviation because sometimes you get a vignette and it just only asks like superior axis deviation, and from these three you will get a one option. It could be Epstein anomaly, it could be atrioventricular septal defect, and it could be tricuspid atresia. Okay. Now, what we have to do in this kind of situation, the same things we have to manage heart failure. It could be medically and surgical repair at 3 to 6 months of age. That's really necessary. Otherwise, baby cannot survive because there could be extreme pulmonary hypertension. The second would be faltering of growth all the time, and third would be like a heart failure. So that's what we have to manage. Yeah, these pictures really describe the AVSD. If you see here, there's really a very bigger defect in atrium as well as in ventricle. And here, this is the leaflet of valve that we were talking about, like tricuspid valves, as well as mitral valve. We cannot see like, it is like three leaflet. It could be five leaflet also. Sorry, four leaflet, one, two, three, and four, but it could be five also. That's what it was described in written section. So if there's really a very large defect like that, there's no turbulence at all in mixing of blood. So that's why we cannot get any murmur here, but there could be cyanosis that could be visible. And the other important thing is, as there's a large mixing of systemic and pulmonary blood, so that's why cyanosis is not that much prominent in first few days, but later on it get more prominent. Okay, as the pulmonary hypertension develops, or if there's any heart failure. Okay, should we go further? Yes. Is it clear still? Okay. Um, the next thing I really want you to remember here is tricuspid atresia. So what happens here is, in tricuspid atresia, only the left ventricle is effective, the right being small and non-functional. So atresia is basically a term where it's really almost a non-formation of a valve. So it means that if there's no valve, there's no right ventricle at all. So that's why it says that the right ventricle being very small and non-functional. What kind of clinical features we get in tricuspid atresia? Now, as we have described previously, what we have to understand is there should always be like a four chambers, okay? So that the circulation could be maintained. So in this form, like tricuspid atresia, what could be the possibility? There could be a possibility of patent ductus arteriosus. There could be a possibility of atrial septal defect, and less likely it could be a ventricle septal defect also. But if there is presence of ventricle septal defect, then we can get a little bit of right ventricle. But um, the main could be the ductus arteriosus and atrial septal defect that's causing all the circulation around. Okay, so what we can get here is common mixing of systemic and pulmonary venous return in the left atrium. You see, there's a connection in the left atrium. Okay, so how the patient presents, there will be a cyanosis in the newborn period if it's duct dependent. So remember that why we're calling it a duct dependent, but you know why? Because the circulation could be dependent on patent ductus arteriosus also. Okay, baby could be well at birth but become cyanosed and breathless. So this is also a major cause of neonate being collapsed. Okay, so management here, what we can do is early palliation to perform to maintain a secure supply of blood to the lungs at low pressure. Because you see, whenever there is like closure of foramen well or patent ductus arteriosus, the circulation cannot be maintained because the pulmonary circulation that would be halted. So what we have to do is we have to create some kind of passage here so that we can supply a blood to the lungs and whole circuit it will go on. Okay. Here, what kind of surgical procedure we need? That could be a bell thoracic shunt between subclavian and pulmonary artery in children who are severely cyanosed. Remember our previous lecture, I told you that you have to go through with these shunts so that she will understand where basically how physiologically we're maintaining the circulation after these kind of shunts. Okay, bella lactosis is basically in subclavian and pulmonary arteries. Now, what else we can do? Now, if the baby is, oh yes, yes, it's there. I will explain it in a few minutes. So, pulmonary artery banding operation to reduce pulmonary blood flow if breathless. Okay, and what else we can do is completely corrective surgery is not possible with most, as there's only one effective functioning ventricle. So how do we perform a palliation here? We go with the Glenn or Hemi-Fontan operation, connecting the superior vena cava to the pulmonary artery after 6 months of age. So if you go here, you will understand that the previous shunt was basically between subclavian and pulmonary arteries. Okay, this is a bellothoracic shunt. Okay, and Glenn or Hemi-Fontan is basically superior vena cava to the pulmonary arteries. Okay, and then the Fontan procedure is connecting inferior vena cava to the pulmonary arteries at 3 to 5 years of age. The left ventricle drives blood around the body, and systemic venous pressure supplies blood to the lungs. That's how basically we go with four-chamber circulation. Now, the problem with the Fontan operation is basically it results less than an ideal functional outcome, but it has the advantages of relieving cyanosis and removing the long-term volume load on the single ventricle. So this is basically our hypoplastic left ventricle. Sorry, if we go here, you see that there is a little bit defect here that's causing like a lot of circulation along with patent ductus arteriosus. That's how the circulation is basically maintained. Now, this is the only one ventricle here. So the problem arises that all the circulation, everything, it just comes up here. So what we do with the shunting is basically this. These are the pulmonary arteries. Sorry, these are the superior vena cava. These are the inferior vena cava. What we try to do is we try to connect these with the pulmonary arteries so that the input that's coming from the body is basically circulated to the lungs, and the blood coming from the lungs, the good blood is basically comes to this ventricle so that it can be transferred to the aorta and the circulation is maintained. Okay, do we have a good understanding about it? Okay, I will go it again. These are the basically pulmonary arteries. Okay, and this is the inferior vena cava. Our parallel tossing is basically what we have to remember is we have to connect these shunts, okay, the pulmonary arteries to the superior vena cava. So it will be easier just to go with the circulation. But our Fontan and Glenn procedure is basically we connect the inferior vena cava to the pulmonary arteries so that all the bad blood that's coming from the body, it goes to the lungs and it should be circulated, and the good bloods that's coming from the lungs. It goes in the left atrium and the left ventricle, and then the circulation it continues. Okay. Okay. Are we clear till now? This is a little bit tricky, but you will really get scenarios with the hypoplastic right ventricle or hypoplastic left ventricle. I would say that the important thing is we always have to understand this, that somehow what we have to do is we have to maintain a four chambers view and four chambers so that the circulation, the pulmonary circulation is different and the systemic circulation is different. So that's how the baby can survive. Okay, let's go further. Aortic stenosis. Here, what happens is the aortic valve leaflets are particularly fused together, okay, and it gives a restrictive exit. So there could be 1 to 3 aortic leaflets. Um, okay, just a general questions. We have four valves in a heart. Which one are basically bicuspid valves and which one are tricuspid, like three leaflet and two leaflet valves? Any idea? Come on, we're digging a little bit physiology here. Three leaflets valves and two leaflet valves because we have four valves in the heart. Anyone? Very good. So here basically tricuspid valve and aortic valve. That's a three leaflet valves. Okay. The other two could be. So what we have to remember is on the right side is it's basically a tricuspid valve, and on the left side it is the aortic valve that has three cusps. Um, that's I would say that's nature because then that's nature that's maintaining all our circulation. That's what it is. Okay. Bicuspid aortic valve is commonly seen in up to 1% of the population, and it may be inherited. Aortic stenosis, I mean, may not be an isolated lesion. It is often associated with mitral valve stenosis and coarctation of aorta. Here, the important thing is whenever we get like aortic stenosis or something, we have to see the other things also, because if there is some kind of associations, that's what we have to basically exclude, so that our baby can survive fully and we are fully aware of all the anatomy. So the association here is basically with the mitral valve stenosis and coarctation of aorta, and it should always be excluded. Now, what kind of clinical features we get with aortic stenosis? It could be asymptomatic murmurs. The second would be reduced exercise tolerance. Number three could be chest pain on exertion. And number four, it could be syncope. Now, why these kind of symptoms we're getting with aortic stenosis only? The reason behind is because it is the aortic valve that really maintaining lots of circulation. Okay, that's why whenever there is a exercise or anything going on, or we're using our body, there could be tachycardia, but the circulation from the aortic valve, it's almost the same that's going on. There could be not so much of cardiac output. That's why we get like reduced exercise tolerance. We can get a chest pain on exertion. We get a syncope also, because the circulation to the brain and the other part could be impaired because of increased demand with all the activity. And that's why we get all those symptoms. Now, the problem here is basically those with the critical aortic stenosis. That's basically a drug-dependent systemic circulation may present with severe heart failure, and it could lead to shock. Because critical aortic stenosis means that that aortic valve is really very narrow, and it's not really maintaining the circulation at all, as all the cardiac output and everything, it's just remaining in the heart. So the problem would be we can get symptoms of heart failure. We can get a pulseless shock also. Now, what we can get on the pulses here, it will be slow rising pulse. The reason is, as we are getting aortic valve is really very narrow, so it takes more times to eject all the blood from the heart. So that's why the pulse initially it will be very slow, but it can go up, and that's why it says slow rising pulse. The other thing we will get here is basically carotid thrill that will always be present. So that's why it is said that whenever you're getting any kind of murmur, you have to put your hand on carotids also, just to see like if if it's a systolic murmur, if it's a diastolic murmur, if we're getting any kind of thrill around. Where we can get a murmur here. So if we remember our areas, I have just remembered those like an APTM. Aorta is on the second right intercostal space. Then pulmonary is on the left intercostal space, and tricuspid is on the fourth left intercostal space, lateral to the midclavicular line. Sorry, medial to midclavicular line, and tricuspid area is in the fifth intercostal space. Just could be around the midclavicular line. So that's how we have to categorize also. With the aorta, we will get a murmur in the right sternal edge, second intercostal space, maximally with the pulmonary area, a pulmonary murmur we will get on the left second intercostal space. With the tricuspid area, we will get maximally at fourth intercostal space, and with the mitral area, it will be on the fourth or fifth intercostal space. But it depends on the cardiac condition also. Okay. Now, the other thing that we get on examination, it will be delayed and soft aortic second heart sound because aortic the heart sounds are basically produced because of closure of the valve. So the second heart sound will be soft because there is aortic stenosis. There's not much of time to close, the valve. So that's why we get a soft aortic second heart sound. As we have described earlier, the investigation basically performed in all those cardiac diseases. These are basically the chest radiograph, the ECG, and the echo. So what we will get on chest radiograph here, it could be normal or prominent left ventricle with post-stenotic dilatation of the ascending aorta. Um, the X-ray, if it is critical aortic stenosis, then there will be a possibility of getting a cardiomegaly on the X-ray. But if it's not a critical side aortic stenosis, it could be normal. But the left ventricle will be prominent, and there could be a globular heart also because left ventricle has to contract against resistance. So that's why the left ventricle is getting prominent. On the ECG, what we will get, that will be left ventricular hypertrophy. What's the reason behind it? As I have explained it to you before, it's basically the left, all the other structures are normal. It's just the left ventricle that's causing, that's basically getting obstructed. So that's why we can get a left ventricular hypertrophy on ECG. And what leads we will see here if we have to check left ventricular hypertrophy? Come on. What leads we will see here for the left ventricular hypertrophy? It's always V3, V4, V5, and V6. And what will be the findings here? They will be like your complexes will be more prominent. There could be prominent P wave also. So how will we manage these patients? In children, we basically need a regular clinical as well as echocardiographic assessment to assess when to intervene, because as we have described about aortic stenosis, what we get on the symptoms is basically breathlessness on exertion, number one. Number two will be problem with the syncope. Number three will be a problem with the chest pain. So whatever we're getting, according to that, we have to basically intervene. And the second thing would be if there is critical aortic stenosis, that's basically an emergency. That's what we have to do it urgently, because otherwise there's no way of getting a circulation to be established, and we can get we can lose the baby. That's what I can tell you. Children with symptoms and exercise or who have a high resting pressure gradient, like greater than 64 millimeter of mercury across the aortic wall, will undergo balloon valvotomy. So there are basically two ways of um, intervention. The one is we can dilate the valve, and number two is we can replace the valve. So what basically they go with first is balloon valvotomy. It's a bit like a dilatation with the balloon. And it is said that it is generally safe and uncomplicated. But in neonates, this is much more difficult and dangerous. So in most neonates with significant aortic valve stenosis that's requiring treatment in the first few years of life will eventually require an aortic valve replacement. Now, the problem with these two interventions are with the balloon dilatation, you can get little bit required effects, but these babies can again go with stenosis, and that's not a really a permanent solution for aortic stenosis. But if we're going to replace an aortic valve, yes, then that's like a permanent solution. Now, early treatment is therefore palliative and directs towards delaying this for as long as possible. So that's what basically explains our situation here. They maximally try to just balloon dilate it, and then just delay it as early as long as possible, so that whenever the definite treatment could be done. Now, this is a normal valve. Basically, it has three cusps, and that's how it is basically described in a way. But this is our stenotic valve. You see, like it seems like that's really a very flexible thing, and that's a little bit of problematic thing. That's how basically it goes on. And the other thing is, if we got a stenotic valve like that, that's why the second heart sound will be little bit decreased with the aortic component. And the next thing that will be a pulmonary stenosis. It's almost the same, but pulmonary valve leaflets are partly fused together, giving a restrictive exit from the right ventricle. It was almost the same, but we are more dependent on aortic valve than the pulmonary valve. So that's why the problem would be more with the aortic stenosis than with the pulmonary stenosis. But still, it depends on if it's like a critical pulmonary stenosis, that's really a major issue, because again, we cannot maintain the circulation, and that will be a problematic then. So here, the pulmonary valve leaflets are partly fused together, giving a restrictive exit from the right ventricle. Okay, what kind of features we can get here? Again, most are asymptomatic, and the second one would be it can be diagnosed clinically, because sometimes it cannot be evident on a fetal echo. The problem with this thing is a small number of neonates with critical pulmonary stenosis have a duct-dependent pulmonary circulation, and then they present in first few days of life with cyanosis or collapsed form. Now, as I was describing it before, our areas for auscultation, APTM. So if it's a pulmonary stenosis, where we can get a murmur, it will definitely be upper left sternal edge. And here, the thrill may be present, but remember that with aortic stenosis, the thrill will always be present. Okay, an ejection click best heard at the upper left sternal edge. Now, what could be effect with pulmonary stenosis? As we remember that, sorry, what could be effect with the pulmonary stenosis? So you see, the right ventricle is really contracting against our pulmonary valves so that it can eject blood in the pulmonary circulation, and then they can be the blood can be saturated, and then it comes to the left ventricle so that the systemic circulation will go on and we can basically get all the oxygen, energy, and whatever we need. Okay. So whenever there is a severe pulmonary stenosis, there could be a prominent right ventricle impulse, like prominent right ventricle impulse or a heave. So yeah, it will be right ventricular hypertrophy. That's true. Now, what we will get on chest radiograph here is normal or post-stenotic dilatation of the pulmonary artery. The second thing will be an ECG. It will show evidence of right ventricular hypertrophy, upright T wave in V1. Now, that's what we were talking about. It could be a prominent heave. It could be right ventricular hypertrophy. It depends on like how bigger is the stenosis. Now, always remember that the heart failure is basically arises when there is excessive pulmonary circulation first. That leads to pulmonary resistance, and then it leads to a decreased pulmonary circulation. Here, with the with the pulmonary stenosis, mostly the patients are asymptomatic and they're not going in a heart failure until unless there's no circulation or there's another lesion associated with it. Okay, as with the pulmonary stenosis, it is really a lesser volume that's going in the pulmonary circulation. That's why they do not go in failure. That's why we have not heard like ever that there was a tetralogy of failed patient that goes into failure. This is the only reason, the pulmonary stenosis. So mostly are asymptomatic. When the pressure gradient across the pulmonary valve on Doppler echocardiography becomes markedly increased, about greater than 64 millimeter of mercury, intervention will be required. So it's basically representing like now the problem has arises in the form of pulmonary valve is really very small or very narrow, and it's not giving us a gradient pressure that's basically required for the circulation. So now we need an intervention here. So how will we treat these babies? We treat these babies with a transcatheter balloon dilatation. That's basically a treatment of choice in most children. Okay, how far we are till now? Are we okay? I want you to ask questions, whatever comes in your mind, till our discussion so that we will proceed further. And I really want to understand that how much you have understood those things very well so that you can get questions right in your exam. Are we clear with the physiology now, like how the system works and how could be the presentation of a heart disease could be? and how we will differentiate, like what kind of what's the basic things that the exam people are asking from us. Okay, should we go further? Okay, dear. The next thing I really want to talk about is hypoplastic left heart syndrome. Here, what kind of things we can see here? It's underdevelopment of entire left side of the heart. Now, here, what will be the problem? The mitral valve is small or atretic. Here, the left ventricle is diminuted, it's diminished, and there's usually an aortic valve atresia. Now, the problem here is basically if the left side is not developed, the problem will be, you know, with the two valve, and that's mitral valve and aortic valve. Okay, and if there's no normal circulation going on through mitral valve, so that's giving us information in the form of there could be really not good formation or no formation at all with the aortic valve because the circulation is really not going on. And in this kind of disease, the ascending aorta would be very small, or almost there will be a coarctation of aorta also. It depends on. This is a really important slide here, and important thing to understand from our CPA1 point of view. Here, they can ask you a physiological questions also, like if there's a hypoplastic left ventricle, left heart syndrome, there could be mitral valve atresia or aortic valve atresia. Okay, and they can ask you questions in a way like how the circulation is then going on. Okay, now what kind of clinical features we got here? It is really detected antenatally on ultrasound screening. Otherwise, it's really very difficult to manage a neonate, as as most of the neonates goes on a palliative care for if associated with these kind of conditions. So that's why if we have antenatal diagnosis, this allows for effective counseling and prevents the child from being sick after birth. The reason is we know this kind of situation very well. Then what we have to do is we have to identify our measures and manage accordingly. It could be a prostaglandin infusion at the start also, because we don't want our ducts to be closed. Otherwise, the circulation will be impossible. They may be identified on oxygen saturation screening if present after birth. Now, the important thing here is whenever we're dealing with a baby, like a neonate one, we basically go with the preductal and postductal saturations. That's how we can categorize those things, you know, and that's basically a saturation screening also. And sometimes, if there is a cyanosed infant or something, what we have to do is we have to understand a hyperoxia test also. And that's basically if we give a baby 100% of oxygen with the oxygen hood and its saturation has improved, it means that the defect is there in the pulmonary areas, like in the lungs. But if the saturation has not improved after giving 100% oxygen with the oxide, it means that the problem is in the cardiac system. Okay, they can ask you about hyperoxia test. Now, the other important thing is they're the sickest of all neonates presenting with a duct-dependent systemic circulation. Now, this is what we just have to remember. The problem with the hypoplastic left heart syndrome is the cyanosis and the way of presentation, like heart failure or something. It will be in first weeks, okay? But if it's like a same kind of scenario with the right ventricular hypertrophy and the progressive worsening of condition and cyanosis and the presentation days, these are basically after first week or after second week. What other our differential diagnosis would be persistent pulmonary hypertension. Okay, I really want you to understand the physiology of these two things, so it will be easier for you just to catch up your answer in exam question. We will go further with one of the slides with the pictorial diagram, okay, with the hypoplastic left heart syndrome. And then it will basically clear up lots of things. And we can basically differentiate then with the persistent pulmonary hypertension and hypoplastic left heart syndrome, okay? Here, the ductal constrictions leads to profound acidosis and rapid cardiovascular collapse. You see here, if we have only one trunk, okay, like with the ventricle thing, what could be the possibility? Like all the blood they're getting mixed up, and all the bloods that's basically going to be supplied to the pulmonary area, not to the systemic area. That's why we got a profound acidosis, because acidosis, it means that we are not getting oxygenated at all. So that's why our tissues are basically trying to go with a non-oxygenated way of protection. So that's why we get acidosis. We know that why we get ketones and everything and acidosis, okay? And the rapid cardiovascular collapse, it is because if we don't have a left ventricle with us, how can we pump our bloods to the systemic circulation? So that's why it's a cardiovascular collapse. So there's a weakness or absence of all peripheral pulses in contrast to weak femoral pulses in coarctation of aorta. This is another differential diagnosis, the coarctation of aorta, as we were describing in our previous session. Okay, so what here is basically how will you differentiate absence of all peripheral pulses in contrast to weak femoral pulses? Because in coarctation of aorta, what's the issue is we can get a radio-radial or radio-femoral delay. It depends on the coarctation, where it is. Is it in ascending aorta or arch of aorta or descending aorta? But with the hypoplastic left heart syndrome, we don't have a ventricle basically that pumping blood to the systemic circulation. So that's why we got all peripheral pulses could be absent. Now, how we will manage this patient? Here, what we do here is basically we would do a Norwood operation procedure, basically just to relieve our things. And as we were talking about before, it's almost the same thing. We just have to create a one ventricle. That's how they do it. And how they do it, basically, they connect the pulmonary arteries with the inferior vena cava so that the circulation could be maintained. The child who have complex lesions or are small for gestational age undergo hybrid procedures. That's basically a combination of cardiac catheter and surgical operation. It's basically what they do is first they put the baby on palliative care until unless the definite surgical procedure is done. Okay. This is again followed by further operation, as we were talking about before, Glenn or hemifontan at about 6 months of age, and again fontan at about 3 years of age. It's almost the same situation as we were talking about a tricuspid atresium, but there the problem was with the right ventricle. Here the problem is with the left ventricle. So that's how they deal. Now, this is our situation here. You see, this is a left atrium and very small left ventricle. That's why we call it hypoplastic left ventricle. And there could be stenosis or atresia here with the tricuspid valve. No valve arises from the from the left ventricle. So that's why it says that there could be a possibility of atretic aortic valve. This is our right ventricle. That's really a bigger one. And all our trunks are basically arising from the right ventricle. So that's why we get sinus every time. And here, our circulation is basically really dependent on atrial septal defect, because here from left atrium to the right atrium, we can get a little bit of circulation. And again, the patent ductus arteriosus, that's basically giving all the bloods to the systemic circulation, including the aorta and everything. You see the degree of cyanosis. We get cyanosis in early life here because there's a complete mixing of blood. Are we clear till here? Everyone, are we clear? Okay, should I proceed further? If you have any queries or something, you can ask about questions. Hello, my students, are we clear? Okay, I thought I have lost everyone. Okay, so what's basically the normal procedure here is what we do is we take this aorta with the patch and everything and attach it to this ventricle, and we use a one shunting from here that basically gives blood to the systemic circulation. That's called shunt. Okay. The first thing is basically creation of yield because that's a palliative care. It's not like we're getting 100% results here, but still. First, they create aorta and attach it to the left ventricle as well as the right ventricle. Then the second thing we do a BT shunting here, and it basically gives blood to systemic circulation as well as cerebral circulation and everything. And the third thing will be like a valve between, sorry, the valve between the atria, it will be removed. So, so, so somehow the circulation that's basically is maintained in a way like we create another left ventricle artificially so that the four-chambered heart, it's formed, and then we go further with the full circulation and we can manage our baby. Here, in all congenital diseases, as I have posed already a lot about, like, four-chambered heart is basically that's what we need, and that's what they basically try every time. Okay? Okay. That was all the congenital heart diseases. And I know it was a little bit boring. Now we will proceed with the further few things that's really important from the exam point of view, and that's basically important important also in general life, because I know after the examination and everything what you have to do is you have to manage all those patients. So having a little bit know-how, that will give you a really a good information and good understanding also that what you are doing with all your babies. Now, we're talking about supraventricular tachycardia here now. Now, it is really a common childhood arrhythmia. The heart rate is rapid, between 250 to 300 beats per minute. Um, Whenever you are really getting a heart rate above 200, okay, there could be a little bit suspicion around with everything, but still the defined heart rate is really about 200, sorry, 240, really, for the supraventricular tachycardia. Now, what kind of complication we can get from supraventricular tachycardia? The first thing, poor cardiac output, because the atrias, they are really contracting by their own way, because that's supraventricular tachycardia. So it is not really connected to the ventricle at all. So sometimes, they can get a feeling, sometimes they cannot. And I know that from physiology point of view, we know that the cardiac output is really lesser dependent on atria, but still it is dependent on atria. And if the atrias are contracting haphazardly, sometimes, the circulation is not possible because all the valve and everything, they have to close, open and everything, okay? The four-chambered heart. So that's why we can get a poor cardiac output. The second thing, it could be pulmonary edema because all the blood that's basically going through the circulation, it's going to be stasis in the pulmonary areas. That's why we can get a pulmonary edema here. Now, how the baby presents with supraventricular tachycardia. It could be heart failure because of poor cardiac output, pulmonary edema, or it could be a little bit asymptomatic, or it could be only the tachycardia. The baby could be pale, non-respondent, anxious looking. That's how babies basically presents. And sometimes you already feel like, okay, it could be just pneumonia or something, but still when you do the examination, everything you see tachycardia, pulse difference, gallop rhythm, pulmonary rails. Okay, what investigation we will do here? ECG. It will show generally a narrow complex tachycardia between 250 to 300 beats per minute. Then, if the heart failure is severe, there could be a changes just as myocardial ischemia. Because generally it is said that MI could cause supraventricular tachycardia, but I would say that not in neonates, not in children, because it is really less likely to get a myocardial infarction in children. I know the things are changing very much now, but still, it is just assumed that not the MI, but we can get a little bit few changes in the form of MI also. And what kind of changes it could be? ECG changes, chest pain, breathlessness, and what kind of ECG changes we are looking basically? T-wave inversion. And we know that it could be ST elevation and T-wave inversion, but specifically here in SVT, you can get a T-wave inversions also. The second problem would be what could be the cause of supraventricular tachycardia? So here there are a few kinds of syndromes associated with these kind of re-entrant tachycardias, and when inside sinus rhythm, a short peer interval may be discernible. If we are getting a short peer interval, there's really a lot of chances of getting a supraventricular tachycardia. In Wolff-Parkinson-White syndrome, known as WPW syndrome. Now here, that's called basically a re-entrant tachycardia. The early antichrate activation of the ventricle via the pathway results in short peer interval and delta waves and a wide QRS complex. Um, I want everyone just to see a ECG of Wolff-Parkinson-White syndrome. There's a typical wave that's called delta waves. If we see a peer interval or how the P waves ends and QRS complex started, okay, there's a typical defined wave that's called delta waves. That's what we have to see whenever we're dealing with the supraventricular tachycardia. But remember that you can see all those delta waves and everything after the tachycardia is settled. Otherwise, it's really impossible to get. Now, what's our main goal here is the restoration of sinus rhythm. Like, however you can do, whatever you can do, restoration of sinus rhythm. So, circulatory and respiratory support in the form of tissue acidosis, it could be corrected, positive pressure ventilation if required, but that's not urgent because with the few maneuvers and starting of medications, a lot of babies come back to sinus rhythm. But that's basically a worst case scenario. Uh, Positive pressure ventilation if required. Now here, what we have to do first, vagal stimulating my ears. It should not be delayed at all. That's what basically latest APLS guidelines are. Whatever you're doing, the vagal stimulating maneuver should be started after the diagnosis is established. And that is basically how we can get it. Carotid sinus massage are cold aspects to the face. And it could be really successful in almost 80% of patients. But the second thing that's really important is intravenous adenosine. That's a treatment of choice. And that's really safe and effective in inducing atrioventricular block after rapid bolus injection. Now, the important thing here is what we have to achieve here is basically the normal sinus rhythm. And adenosine, it really acts on sinus SA node and slows it down. And also, it really try to act on atrioventricular areas also, so that there would be a really restoration of sinus rhythm. How sinus rhythm is produced? If we go with our physiology now, all the impulses that basically started on SA node, then it goes to AV node, then to the Purkinje fibers, to the ventricle and to the ventricles. Okay, so basically the AV node is really physiological hindrance because atria can contract very easily and it can contract above the rate also. But it's basically the AV nodes that really maintains circulation of ventricle, and with all the ventricle circulation, we can get our cardiac output. Now, the other thing would be it terminates the tachycardia by breaking the re-entry circuit that is set between the atrioventricular node and accessory pathway. And sometimes what we have to do is we have to repeat more than one dose also. Okay. If all the measures unsuccessful now and the baby has just collapsed, okay, after our medications also, then what we have to do is we have to go with a synchronized cardioversion, okay, DC shock, and the doses would be 0.5 to 2 joule per kg body weight. Now, in SVT, I really want you to understand vagal maneuvers, first choice without any delay. The second thing will be adenosine, okay? And if we have not got any control with adenosine also, what we have to do is we have to go with the synchronized cardioversion. These three domains should be in your mind whenever you're dealing with the SVT. And I would be honest with you, probably you will get a one scenario with the SVT because that's really a common finding here. And um, in Ireland, you will get a lot of babies with SVT. Now, regarding the causes of SVT, as we have described some genetic causes, okay, like WPW, accessory pathway, and anything, the SVT can be occurred with few other things also, and that's basically fever, any respiratory or some kind of infections, okay, and the third one would be hyperthyroidism. Okay, these three conditions can also present with the SVT. So finding the basic cause for SVT is really important here. Okay, what other things we will get? Now, once the sinus rhythm is restored, maintenance therapy will be required with the flecainide or sotalol. It really depends on what was the cause of SVT. If it was like reentrant pathway or something, then we can use these kind of medications, but not regularly. Okay. Now, the digoxin can be used on its own when there's no overt pre-excitation waves like a delta wave on ECG. So just remember that. Digoxin, what it does basically, it slows down the heart rate. That's what the main goal around using digoxin is. But it is really contraindicated if we have any pre-excitation syndrome, okay, like WPW. If that kind of situation exists, what like a pre-excitation syndrome, what we have to use? We have to use a propranolol. Okay. Now, the other thing is, if the resting ECG may remain abnormal, but still the 90%, if we use, then what we use is basically propranolol or something. 90% of children will have no further attacks after infancy. That's really a good thing, but still you have to be more careful. Treatment is stopped at 1 year of age if there's no Wolff-Parkinson-White syndrome. Okay. What other thing you all have to remember is we do not start any medications on one attack only. Okay. If it's like recurrent SVTs, then we will start medications. That's why it is just written here. Our treatment is stopped at 1 year of age if there's no WPW syndrome. But still, it depends on if there is a recurrent SVTs going on and everything, then we will continue our treatment. Now, what we will do if we got pre-excitation syndrome like Wolff-Parkinson-White syndrome, what we have to do is we have to go with ablation therapy or atrial pacing. Well, with the ablation, basically, we remove the connection with this pre-excitation pathway, okay, and then the re-entrant pathway is blocked, and we really then did not get any kind of SVTs at all. With the atrial pacing, it's basically almost the same thing. The pacing is giving you impulse at a defined time, and with this defined time, the pre-excitation pathway did not get any time at all to activate, and then the smooth SA node activation is going on, and no reentrant pathway and no SVT. So this will reduce the small chances of sudden death in such patients. That's really required thing for us. Now, the last thing here, those who relapse or are at increased risk are usually treated with percutaneous radiofrequency ablation or cryoablation of accessory pathway. That's what I was talking about before. So this thing is a definite treatment here. Okay. And this is like smooth running thing. But it depends on if the babies are going very well with this atrial pacing. We don't need to do an ablation because that's a little bit tricky procedure. Yeah, this is the ECG. I want you to remember it very appropriately. Okay. How do we calculate the rate here? Is 300 divided by large boxes. Okay. It's almost 1.5. So not 1.5. I would say it's just 1. So heart rate is going to be almost 300 or more than 250 above. Okay, we cannot see any P wave, and we cannot differentiate much of a T wave also, but there is prominent T wave here, no P wave at all. Only just the QRS complexes that's going on. So that's a typical ECG for SVT. Okay. Are we clear? That's great. Are you all following everything? I am trying to go with all the basics because RCPI-1 is really going with all the basics, and RCPI-2 will be a little bit more like a clinical based thing. But still, if you follow through all those things, you you will really ace your exam. Do I need to further elaborate the SVT, or we are okay? Great. Okay. Now, congenital complete heart block. Sometimes we get at these kind of situations, but there are a few things that warrants us before, so we can manage our things very well, or maybe in higher centers if needed. This is a rare condition. It is related to anti-Ro, anti-La antibodies and maternal serum. Now, this condition is really associated with maternal SLE, and they will ask you about these kind of antibodies. Congenital heart block or heart block is associated with which kind of maternal antibodies? That's anti-Ro and anti-La antibodies. Okay, just remember this. Now, the other thing will be this mother will have either manifest or latent connective tissue disorders. So that's what I was talking to you about. Um, if you go with the neonatology, when we get all the history and everything, we basically ask those kinds of questions also, that is there any chronic disease that's going on? And people are really very much um, aware of their disease also. Then they basically describe like, yes, I have this kind of condition and I have been followed by this team, or if they have done any um, antibodies or something. Okay. So if I get a mom with established SLE, though if she is on any kind of treatment or not on any kind of treatment at all, but still my priority as a pediatrician or as a neonatologist would be just to know these antibodies, that if they're there, I would have a little bit warning in my head that I have to do an ECG as early as possible and do a cardiac examination, including pulses. Okay. The subsequent pregnancies are often affected. That's really important. And the reason behind is these kind of antibodies really prevent normal development of electrical conduction system in the developing heart with atrophy and fibrosis of atrioventricular valve node. Sorry. As I was describing you before, um, it is mainly the AV valve that's really, AV node that's really controlling our circulation because we are really dependent on our ventricles until unless they're not getting filled. Okay. Now, you know that we can get a fetal heart rate in first few weeks of pregnancy. So if there's no problem with like congenital heart block, what we can there could be lots of complication in the form of fetal heart drops. Could be worst case scenario, death in utero, heart failure in neonatal period. Depends on how the baby presents. But really, the good thing is most of these babies remain symptom free for many years, but a few with this symptomatic with the pre-syncope or syncope. Now, here, the most important thing, that's why I was talking about that we have to contact to heart centers or those with intervention also, because if the baby is symptomatic, what we have to do is we have to insert a endocardial pacemaker, like pacemaking, because that's what at the time the treatment of choice is. As there's a block, we have to relieve that block. Okay. And the only way here is the pacing so that the circulation is established and baby start to improve. Okay. Another important topic, syncope. Now, how will we define a syncope here? It is basically transient loss of consciousness with loss of postural tone and then spontaneous recovery. Now, I want you to focus on those things, that is transient loss of consciousness with loss of postural tone and then spontaneous recovery. That's how the definition of syncope is. Now, what's the pathophysiology behind this? It's basically transient impairment of brain oxygenation and impaired cerebral blood flow. I am forcing on this syncope is if any one of you have worked in ED, you will get a lot of patients with the syncope. And then RCPI basically try to choose those things which are very common and really yielding steps. Okay, so that you really have a good grip for the clinical point of view, from the clinical point of view, and you do not miss things. Common in adult sense and it's usually benign. Rarely it is due to cardiac disease, which may be life-threatening. See, it gives us both things, that it is usually benign, but if associated with any cardiac disease or something, it's really life-threatening because syncope is loss of consciousness. And you see, the problem would be like if you got your loss of consciousness at any point, that's not safe, then you can hit your um, head. You can get in some kind of accidents. It depends on what kind of situation you are working on and you got a syncope. Now, most important thing is vasovagal syncope in response to a range of provocation and stress. And it could be orthostatic intolerance in the form of standing up too quickly. And the other problem could be sudden, unexpected pain. Basically, it can. I mean, these sentences really want to define like there could be some kind of stimulant that's causing those kind of issues, like sight of blood or needle, unexpected pain, standing up too quickly. These kinds of issues can cause a vasovagal syncope, and that is basically loss of postural tone and loss of consciousness. And the reason would be impaired brain oxygenation and impaired cerebral blood flow. So, clinical features here. With the syncope is, if you get a scenario like that, that the girl describe her unconsciousness in a way that she got a, a kind of funny feelings before getting a unconsciousness. Okay, that's basically a syncope. Funny turns, funny feelings like that. That's basically typical way of description for syncope. So the prodrome of dizziness and lightheadedness first. Then we can get abnormal vision, often with nausea, sweating, and pallor. Okay. Worst case scenario, when associated with jerky movements, it can be misdiagnosed as epileptic seizures. Now, I know that that's really a unusual presentation, but yes, it is a possibility that they can get a jerky movements also because it is an impaired flow to the brain, like a cerebral anoxia thing. Am I clear? In most episodes, there is maladaptive drop in blood pressure, and in significant minority, there's a marked fall in heart rate and asystole also. This is previous kind of situations that we get from syncope. As there's a postural height tone decreased, it means that the peripheral vessels they are dilated early, so leads to peripheral pooling of blood. Okay, and what we will get from here is basically we can get a bradycardia as well as tachycardia. It depends on, and sometimes if you know the circulation is really not so is so much compromised, we can get an asystole also. Worst case scenario. Now, what kind of features basically that's suggested of cardiac causes or symptoms on exercise that's potentially dangerous, family history of sudden unexplainable death that's dangerous, and palpitations. Um, what we have to check here is basically whenever you get a patient with the syncope, most important things is check blood pressure and for signs of cardiac diseases in the form of murmur, femoral pulses, any signs of Marfan syndrome. You know why it has mentioned Marfan? Because of involvement of aortic valve. That's what we were talking about before. The aortic stenosis can cause syncope. So that's why we have to go with those things. What we have to check here, other than the blood pressure, that's basically 12 lead ECG and corrected QT interval. Because long QT is also associated with syncope. So that's why we need a QT interval, 12 lead ECG. We need a 12 lead ECG to check all the rhythms, rate, and everything going perfectly well. Then all the intervals that's going on perfectly well. If there's any chances along with that, like QT interval prolongation or long QT syndrome, then it's a possibility that we have to treat those things. Okay. Now, other important topic, heart failure. It's really important because a lot of things are associated with different kind of presentation. So we have to keep in mind. The signs and symptoms for the heart failure would be breathlessness, particularly in feeding or exertion. Okay, sweating, poor feeding, recurrent chest infections, poor weight gain or faltering growth, tachypnea, tachycardia, heart murmur or gallop rhythm, enlarged heart on investigations, on examination. It could be hepatomegaly and cool paraphrase. Now, there are few things that's basically symptoms. There are few things that are sign here. I would say that till poor weight gain or faltering growth, breathlessness, sweating, poor feeding, recurrent chest infection, poor weight gain or faltering growth, that's basically symptoms. Now, tachypnea, tachycardia, heart murmur, gallop rhythm, enlarged heart, and hepatomegaly, cool paraphrase. That's basically you will get as a sign for the heart failure. So whenever you got a few symptoms from the parents with those things, then there should be a slight thing that's going on, like heart failure in your mind also. Then you have to exclude all the other things on your examination. Signs of right heart failure. Now, how we will see like it is right heart failure or it's left heart failure? The right heart failure basically really presents with all the fluids that's retaining in the body in the form of ankle edema, sacral edema, ascites. Well, it says that it's rare in high income countries, but I don't know. Depends on. But it's basically it could be seen with long-standing rheumatic heart disease, pulmonary hypertension, tricuspid regurg, and right atrial dilatation. Now, important things to remember: causes of heart failure. Well, in units, you know, the heart failure really will be like from duct dependent lesions. Or the second thing would be congenital heart blocks. Otherwise, really, there are not so much of causes that really associate with heart failure in neonates. Now, these kind of lesions, as we were talking about, was hypoplastic left heart syndrome, critical aortic stenosis, severe coarctation of aorta, interruption of aortic arch, and then in children, we can get a cardiomyopathy also. There are a few metabolic diseases that's basically associated with cardiomyopathy in infantile period. Okay, like GSD type 2, like that. But I think not at this moment. You have to remember with the part 2, basically, you just have to remember those things also. But we will discuss the metabolics probably, and then I will explain the cardiomyopathy there associated with metabolic diseases. So in infants, the causes of heart failure would be high pulmonary blood flow, like ventricular septal defect, atrioventricular septal defect, large persistent arteriosis, and older children and adults could be right or left heart failure, depends on. Then, as we explained earlier, Eisenmenger syndrome and some acquired causes like rheumatic heart disease, Okay, these could be the causes of heart failure in neonates and infancy. And then, as we were talking about, there could be like acquired causes also. Are we clear now? Till now? That's great. Any questions? Are you understanding things very well? Okay. Now we will go with some acquired causes because that can come in an exam. Okay. Now, rheumatic fever and rheumatic carditis. That's basically two different entities, but comes with the same kind of infection with the organisms. Okay. So, what is rheumatic fever? So, acute rheumatic fever is a multi-system autoimmune response to a group A streptococcal infection. And sometimes it can go with the strep epidermidis also, like those involved in the skin, but mainly it is group A streptococcus. It mainly affects children aged 5 to 15 years and may progress to rheumatic heart disease. Now, it is, as I was explaining to you, it is multi-system disease. So if it is affecting the heart, then it is rheumatic heart disease. There's a higher incidence in low and middle income countries, mainly related to environmental factors, especially household and overcrowding. As you know, group A strep is basically involving the upper respiratory tract, throat, and everything. So in those places, which is really overcrowded, and those socioeconomic countries, they really because of space and everything, that's really transferable disease. So that's why it is more common in there. The other thing will be difference in streptococcal virulence may also be a factor in that. Now, antibiotic treatments of streptococcal pharyngitis play only a minor role in reducing incidence. So that's why a 10-day course of antibiotics for group A streptococcal pharyngitis is required for prevention of acute rheumatic fever. Now, this thing I want you to remember, the 10-day course. Okay. Now, what are the clinical features here? After a latent interval of 2 to 6 weeks following group A streptococcal pharyngitis or occasionally streptococcal pyoderma, that's what I was talking about. The second thing, okay? What we can get here, acute febrile illness with, it could be polyarthritis, carditis, Sydenham chorea. These are the presentation. And then, we know that it could be erythema nodosum also. So that can also explain. I have just explained all the criteria for diagnosis of rheumatic fever later. But there's usually an evidence of group A streptococcal infection in the form of acute phase reactants like increased CRP, ESR could be raised. And how we do our cardiac evaluation here is with the ECG and echocardiography. Okay, we all know that. Oh, I'm sorry. Sorry, we all know that we can get an increased peer interval in group A streptococcal infection. So that's basically minor criteria, but we will explain it later in a few minutes. Now, the most common form of a long-term damage is to the cardiac valve from scarring and fibrosis of valve tissue of the heart. The most commonly valve that's affected is mitral valves, then aortic, tricuspid, and rarely pulmonary valve disease may occur. So that's really important. We just have to remember the valve also, most commonly affected valve here. Okay. Okay. So um, how do we diagnose a rheumatic fever? With all those criterias, basically after the sporting evidence of preceding group A streptococcal infection from the other kinds, what we need are two major or one major, two minor criteria to make our diagnosis. And how do we calculate the evidence for infection? That is basically raised ASO titer or positive rapid streptococcal antigen test or positive group A streptococcus and throat culture. That's really important. Plus, we will get these criteria. What is the major criteria here? The major manifestations are migratory arthritis. That's basically 50%. That could be an ankle, knees, and wrist. The important thing is how will the patient describe his finding. Will say that I had a pain in my ankle joint yesterday night, but today I'm feeling like I have a knee joint pain or a wrist joint pain. That's called migratory arthritis. That's really an earlier symptoms, and sometimes we can see like there's a exquisite tenderness also on that joint. So what's important here is we don't have to confuse things with septic arthritis here. Okay, it's just a tenderness. Moderate redness could be a possibility, or swelling. It depends on. But if we have evidence, then we will weigh our things in like it could be a septic arthritis or it could be a rheumatic arthritis. Okay, really, the differentiate point here would be migratory. Less than 1 week, any joint or swelling, then it will be migrating to the other joints or 1 to 2 months. So migratory polyarthritis or arthritis is really a manifestation of rheumatic fever. The second thing is carditis, 60%. Endocarditis main features are significant murmur or valvular dysfunction. So we can get our symptoms in the form of myocarditis that may lead to heart failure and if not treated very well, worst case scenario, death because we're dependent on our heart. And pericarditis. And pericarditis in the form of pericardial frictional rub, pericardial effusion, tamponade, or valvulitis. Valvulitis is basically associated with endocarditis. And we can get these kind of findings on our echocardiography. But, there are a few things that basically visible through, sorry, that can be known through ECG also. That like on myocarditis, we have um, low voltage ECG on pericarditis. We can get a like high voltage ECG. All the waves would be tall on chest and limb leads and tall T waves, short ST segment like that. Oh, sorry. Migratory arthritis, we have described it already. Then erythema marginatum, like it's uncommon early manifestation, rash on trunk or limbs, pink macules spread outward, okay, causing pink borders with a fading center. That's what really, you can see things with erythema marginatum. The center would be really fading, but the periphery, the borders will be pink. Now, the borders may unite to give a map-like outline. That's I would advise you after this, go on a Google just to see like what's lithium marginatum look like. If you see a picture today, you will never forget. Now, the third thing, Sydenham chorea. It usually presents 2 to 6 months after the streptococcal infection, and Sydenham chorea is involuntary movements and emotional lability for 3 to 6 months. Usually it resolves itself, but if it's not, then haloperidol is really the drug of choice here. Remember that, Sydenham chorea, haloperidol. The fourth one is subcutaneous nodules, less than 10%. It is painless, pea-sized, and mainly in extensive surfaces of our elbows especially. It could be a possibility that we can find subcutaneous nodules on our shin also. Now, I want you to remember a major criteria through the word Jones. So how did I remember those things is from J, it's joints like arthritis. With O, you just have to remember like it really mimics like cardiac thing, carditis. Then N, subcutaneous nodules. Then E, erythema marginatum, and then Sydenham chorea. That's how I remember criteria, the major criteria. Now, the minor manifestations are it could be fever, arthralgias, raised acute phase reactants like ESR and C-reactive proteins, and prolonged peer interval on ECG. Remember that how we will diagnose it? Supporting evidence, and then after that, two major or one major and two minor criteria. Just remember this thing, okay? Two major, one major, two minor, along with supporting evidence. Now, what's the immediate management? Immediate management is focused on alleviation of symptoms, and what we have to use is NSAIDs for arthritis and both for acute inflammation as well as prevention of new joint involvement. The first thing. The second thing is aspirin. Aspirin has been used traditionally to suppress the inflammatory response of joints and heart. But now they're trying to go with the naproxen, but still aspirin is still a drug of choice here. Now, what will happen with the severe carditis or cardiac failure? We will go with the steroids. And the second thing would be a bed rest. So indication here is if the baby is presented with rheumatic fever with carditis, okay, what we have to go with, it's NSAID plus aspirin, okay. If the baby is presenting with rheumatic fever with carditis and heart failure, then we will go with the aspirin and glucocorticoids. That's what we have to remember, okay. And bed rest, that's really needed. A palliative thing, but that's needed. Now, about the Sydenham chorea, it's usually managed with psychological, educational, and social support and haloperidol until it's resolved. Okay. If they're asking about the medication, then it is haloperidol. Okay, and otherwise it's basically a psychological issue, and with education and everything, it's a self-limiting disease and it goes very well. But if it's not going very well till 6 months of life, still there's an indication for haloperidol. Now, group A streptococcus carriage is eradicated with penicillin. Okay, household contacts with gas positive throat culture should also be treated because the problem arises whenever we're getting a recurrent infection. Then our immune system will react in that way, and that will lead to molecular mimicry and multisystem autoimmune disease. Now, how will we will monitor our disease activity? That could be monitored with serial CRP measurements. Now, our main aim would be recurrent of gas infection should be prevented as severity of eventual rheumatic valvular disease relates to the number of childhood episodes of acute rheumatic fever. I was talking to you before in that way that what's more important is the recurrent infection. If we are going with the recurrent infection, then there are higher chances of getting rheumatic heart disease. And the most commonly valve involved is mitral valve. Yes. The other thing that's really important here is a prophylaxis. Now, prophylaxis is most effectively achieved with monthly injection of benzathine penicillin. Okay. Alternatively, we can use the penicillin. It can be given orally, but it's less effective. And the other could be the compliance. That could be a problem. Okay. Changing to oral medication may be appropriate for young adults who have remained free of further attacks of acute rheumatic fever. Now, we will define our time duration. If it's just a rheumatic fever, we have to give a prophylaxis till 5 years. Okay. If it's rheumatic heart disease with carditis, but without residual disease in the form of no mitral valve residual disease, no other valve residual disease, so the prophylaxis will be 10 years at 21 years of age, whichever is longer. That's what we have to remember. And if it's rheumatic carditis with residual heart disease, then it's 10 years or 41 years of age, whichever is longer. Sometimes, the lifelong, because it depends on at what age it is started. And what we have to complete here is 41 years of age. So sometimes it's lifelonger. Okay. Now we will go with our most important acquired disease. That's called infective endocarditis. Now, okay. Are we okay? Should I proceed further? Anything to ask about rheumatic fever? Are we clear with the rheumatic fever? Okay. Regarding infective endocarditis, all children of any age with congenital heart disease, including neonates, are at risk of infective endocarditis. What's the definition of endocarditis? What's the definition of endocarditis? It's the inflammation of endocardium, especially the valvular areas. So just remember that the valves here, okay? The risk is highest when there's a turbulent jet of blood, as with the VST, correlation of aorta, PDA, or if any prosthetic material has been inserted at surgery. So infective endocarditis is really difficult to diagnose, but it is a differential diagnosis of fever of unknown origin with raised ESR, unexplainable anemia, or hematuria. Okay. Now, what kind of clinical signs we can get here? First thing, fever of unknown origin is like 1 month visit, an OPD visit with all the investigations, or 15 days hospital admission with all the investigation, but still you cannot get a cause for that. That's basically fever of unknown origin. But here, clinical manifestation, it started from fever first, anemia and pallor, then splinter hemorrhages in nail beds, clubbing, necrotic skin lesions, splenomegaly, neurological signs from cerebral infarction, because with infective endocarditis, basically it is a valve, the heart, that's involved, and we can get a few thrombi that basically goes to the systemic circulation and can get infarction. Then retinal infarcts like rod spots. Okay. Then other thing would be arthritis or arthralgias, hematuria. It could be microscopic, new onset of murmur or changing murmur, congestive heart failure, Osler's nodes or pulp of fingers, Jamilians, non-tender patches over palm. Okay, am I clear? Now, diagnostic criteria for infective endocarditis. Oh, it's called modified Duke criteria. Okay, consists of major and minor criterias. So the major criteria here is blood culture that's positive for typical microorganism for infective endocarditis in the form of Viridian streptococcus, Streptococcus glyticus, Hastic group, community occurred enterococci in the absence of primary focus. Next, positive blood culture from microorganism consistent with endocarditis, that's basically persistently positive. Blood culture drawn 12 hours apart, that's showing really the same organism. All three or majority of greater than 4 or equal to 4 blood culture with the first and last drawn at least 1 hour apart. Okay. Single positive blood culture for coxiella. Oh, sorry. Yeah. A single positive blood culture for Coxiella burnetii or phase 1 IgG titer 1:800 ratio, greater than 800 ratio. That's basically a major criteria. One thing, blood culture. The second thing is positive echocardiogram for infective endocarditis. Now, What we can get on echocardiogram here is oscillating intracardiac mass, a valve or supporting structure, okay, abscess or new partial dehiscence of prostatic valve, new valve regurgitation, worsening or changing of a pre-existing murmur. That was basically major criteria. On major criteria, there were two things: blood culture, echo findings. That's what we have to remember. Okay. Regarding minor criteria, now, predisposing heart condition or intravenous drug use, fever and temperature greater than 38 degrees, vascular phenomenon could be major arterial emboli, septic pulmonary infarct, mycotic aneurysms, and intracranial hemorrhage or chainway lesions. And regarding immunological phenomena in the form of glomerulonephritis, Osler's nodes, as we were talking about, it's on the pulpal finger, rot spots, it's in the eyes, and rheumatoid factor. Microbiologic evidence, positive blood culture, but does not meet the major criteria, and echocardiography consistent with infective endocarditis, but does not meet the major criteria. Look, here basically, if they ask you questions about infective endocarditis, something, they will really ask you to fill the criteria, to fulfill the criteria for infective endocarditis. And what you have to remember is how many major criteria is included, how many minor criteria is included to make the diagnosis, and that will be really associated with fever of unknown origin also. That's how basically they goes. Otherwise, they will give you questions in the form of Janewilians, like on the palms and sole, rot spots, what's in the eyes, Osler's nodes, like that, and they'll give you a positive blood culture that probably does not meet the criteria, like it's not the typical organism that's causing, okay? That's how basically they trick you up, but you have to be more careful because you want to pass your exam. Now, how will we diagnose that it's definite endocarditis? Here, if we are fulfilling two major criterias, one major and three minor criterias, or five minor criterias. Do you want me to go again with the criteria, or we're okay? Okay, that's basically a modified tube criteria. Okay, with the major criteria, there are two things. That's basically positive blood culture and positive echocardiography finding for infective endocarditis. With the positive blood culture, if it is positive for two separate blood culture that's positive with the typical organisms, that's Viridian Streptococcus, Streptococcus calyticus, Hastig group, community acquired enterococci in the absence of primary focus. That's basically Streptococcus sanguinus. Then persistently positive blood culture for microorganism consistent with endocarditis. Okay, blood culture positive that's drawn 12 hours apart with the same organism. All three or majority of four blood culture with first and last drawn at least 1 hour apart, and single positive blood culture for Coxiella burnetii or phase 1 IgG titer 1 ratio greater than 1 into 800. That's basically with the blood culture and immunoglobulin. Okay. Echocardiogram finding would be oscillating intracardiac mass on valve or supporting structure. That's a new onset. Okay. That's called vegetations also. Abscess are new partial dehiscence of prosthetic valve if there is surgery performed still. New valve regurgitation or worsening or changing of previously existing murmur. Okay. With the minor criteria, we got a predisposing any heart condition or intravenous drug abuse, fever with a temperature of greater than 38 degrees centigrade. Then there are a few vascular phenomena in the form of major arterial emboli, septic pulmonary emboli, and mycotic aneurysms, and intracranial hemorrhage and Janeway lesions. That's basically called the vascular phenomena. Then immunological phenomena in the form of glomerulonephritis, Osler's nodes, Roth spots, and rheumatoid factor. That's immunity developed things. And microbiologic evidence with the positive blood culture but does not meet the major criteria. Echocardiography consistent with infective endocarditis but does not meet the criteria. Now, are we okay now? Anything that's missing? So the definite endocarditis here is that will include two major criteria or one major and three minor criterias and five minor criteria. Now, this is really important in the form of they will ask you about prophylaxis. So there are a few high risk lesions, few moderate risk lesions, and few low risk lesions. Regarding high risk, it is VST, patent ductus arteriosus, tetralogy of Fallot, coarctation of aorta, prosthetic heart valves, mitral regurg, aortic regurg, and aortic stenosis. They say that we have to give a prophylaxis whenever these kinds of conditions are there. Regarding our moderate risk, include lots of stenosis, including pulmonary, mitral, and tricuspid stenosis, then tricuspid regurgitation, mitral valve prolapse plus mitral regurgitation. Regarding our low risk things, that's basically atrial septal defect, mitral valve prolapse without mitral regurg. With the low risk, we don't need to. With the moderate risk, we have to consult with the cardiology to get the prophylaxis for any kind of procedure that's going on. And with the high risk, I think we definitely have to give a prophylaxis. Okay, now we will go with the myocarditis or cardiomyopathy. That's really a type of acquired disease. It's basically dilated cardiomyopathy, a large, like poorly contracting heart. It could be inherited or it could be secondary to metabolic disease. Or there is possibility of getting a direct, I'm sorry, it could be secondary to metabolic disease that results from direct, sorry, or it could be a possibility of direct viral infection of myocardium also. So it should be suspected in any child with an enlarged heart or heart failure who was previously very well. That's how the presentation here is. With the myocarditis, basically, how typically babies presents, they get respiratory infection still for the last 1 week, and then they come with a collapse condition. That's how we basically diagnose as a myocarditis. And with the ECG, what we can get here is basically low voltage ECG. You know, whenever there's a really dilated heart, there's really less time for the impulse to conduct from the heart, and on the ECG we will really get a low voltage ECG because of this reason. Okay. With the diagnosis is really made on echocardiography, but on X-ray we can get already a large heart. Now, treatment is really symptomatic. Diuretics and angiotensin converting enzyme inhibitors, that's basically used. And if it's needed, beta blockers or really treatment of choice, because what we have to do is we have to slow down the heart so that it did not go in any kind of arrhythmias or something, as well as it can perform its function. And sometimes, you know, we just have to use a digoxin also. It depends on the condition. Now, the role of steroids and immunoglobulin in VN is controversial here, not for the myocarditis, but nowadays they're using another drug also that's called milrinone. Just remember that, because it is chronotropic plus traumatropic. It can affect both heart rate and contractility at the same time. So just remember the name for this drug also, milrinone. Myocarditis really improves spontaneously, but some children ultimately require heart transplantation. It depends on how the things going on. And then the other cardiomyopathies that could be hypertrophic and restrictive are really rare in childhood and usually related to systemic disorders. Now, these diseases, the Hurler and Pompe's, we will describe in metabolic conditions, and the Noonan we will describe in genetics. Okay, that's and for today. I want you to give me a feedback. And really, I want to ask you if there's anything, any ambiguity or something, just go on, just ask your question. So I really want you to pass your exam. That's my goal. And tomorrow, yep, go on, please. Um, I would be honest with you, it depends on your luck that what kind of paper you got. But with the part one, not so much deep, like you're not going to be consultant, you know, after part one. That's what I would tell you. That's why I'm really going with the basic things, not so much deeper that you feel like you have lost your pace. I will give you whether tomorrow or the next session. Okay, I will give you a few basic questions also in the form, like in the form of format, so you will understand how the questions will. That's really an unfortunate with the RCPI because not so much people were really into it, so there are not not past papers collection like RCPCH. But yes, I will provide you a few scenarios. Then you will see like how the paper are. Okay. Any further questions? Also give me a feedback also so that I would know that how I'm teaching. That's great. I would say that bye for today, and I will meet you up in the next section. Thank you so much. But if you have any ambiguity or queries, just let us know that we can then deal with all those things. Okay?